Now we talk about the surgery for the back pain and the various patchy pains, that is knee pain, groin pain, heel pain and coccygeal pain. If these pains are very severe and unrelenting and do not respond to any form of therapy. Now the surgery for the back pain basically would be related to an annular tear in the posterior annulus, which is not healing because of trapped nuclear fragments in the central part of the annulus. So we will be talking about how we access that, how we land there. What we do is we follow the standard line drawing and we access the foramen. We land in the foramen, go inside the disc right up to the midline, and we use the hook to find out which area of the annulus is weak or torn. And once we are there, we remove the trapped nuclear fragments. We may use the flexible graspers so that we are able to reach much dorsally in the tear and get all the material which is lying there. Then we think of healing of the annulus. Now healing of the annulus is one of the main problem areas which are tackled by use of biological solutions. The annular opening which is made in the open surgery is a problem area. The annular tear which causes the symptoms is another problem area. The annular opening done during endoscopy is one more annular opening related problem area. Now these annular openings nowadays in open surgery are stitched back by sutures or by using gadgets like X-close or InClose. But in our surgery, the endoscopic surgery, we try to close the original annular opening giving symptoms and a new annular opening done by the surgeon by use of L-platelet-rich fibrin plug. We'll be talking about it very soon. In the past, when the surgery for the back pain was not very common because the etiology was not understood very well, we started observing the central area of the annulus from inside, started cleaning the annulus and making a annuloplasty. Then we found that it can give rise to relief of back pain very soon. Then over a period of time, when surgeons started concentrating on the disc herniations, there was a small area of back pain where you may tackle that without actual endoscopy, but by putting a small tube of about 4 mm inside the disc, go to the central area because that is where the pain causation is, and use a RF tip, a probe or a small grasper and remove the trapped nucleus. So this was proposed as a disc FX, as a new system for treatment of that central annular tear and the trap fragments. In these central tears, what happens is the annulus gets torn, there is a piece of nucleus which sits there, and this doesn't come out, this doesn't go in. It makes the annulus lose its concavity, which is normal. Now this loss of concavity definitely indicates a small fragment of 2.5 mm sitting in a disc, commonly at 4.5 or 5.1. If this sits there and heals with a lot of collagenization, this can also give rise to central stenosis because the cause is in the front. The disc is not collapsing, the ligamentum flavum is not involved, but the patient may get claudication. And we have to remember that in younger patient, in the third decade, there may be severe back pain because of the disc-related causes, as we just mentioned. Now these disc-related causes are almost unknown to majority of open surgeons because they never look at the MRI with that finesse. They are not aware of annular tear, they are not aware of trapped nuclear fragments, they are not aware of chemical leakage because they don't do a discogram ever, and therefore the only thing which they think about is a black disc and a fusion for all these patients, which is absolutely unnecessary. The economics of back pain in younger individuals is very significantly tilted towards heavy metal surgery, which is irrelevant. We need to understand that there is a humongous number of patients who are suffering with back pain because of a posterior annular tear, which is a very simple problem. But even though we understand this worldwide burden and the uncertainties with open surgery, still the open surgery is proposed as a solution. Excuse me. I would show you the futility of doing open surgery in these patients by showing you all the layers of tissue which we cut and go in. So here we see the posterior aspect of the patient. Assume that the patient is lying prone and you are looking at the posterior midline between the two paraspinal muscles. Now we go further and we find that we start seeing the spinous process. We normally would cut the muscle next to the spinous process and erase the muscle with a Cobb's elevator or osteotome to make it sharper. And then we erase it almost up to the paraspinal line. That is, we erase the muscle from here right up to here, so that we expose the full extent of the lamina and the facet joint there. Then we go down, we start seeing the facet joints. We go further down, we see as if we are removing the posterior midline structures, and then we start seeing the dural sac after removal of the spinous process, interspinous tissue, interspinous, supraspinous ligaments, and the ligamentum flavum. And now here, for example, the patient has a narrow canal. So instead of thinking about what is actually causing the problem, we start doing a wider laminectomy and make this further wide and make the canal wider. Now here we have to remember that these are roots which are coming out. This is the disc. This is actually the Cambian's triangle. This is the dorsal root ganglion below the pedicle. So for a pathology which may be lying in the front of the dural sac in the form of disc herniation, we are using a posterior midline axis and we cut so much that it is very morbid. Now we are still further inside and now we see the dural sac and we see the block, and then we go further and we see the disc. The point of showing these images was to show you that this is a gross surgery. This is a morbid surgery. There is no understanding about the etiology in this patient. So let me say that in our case, in our system, we go directly for the disc, we land inside the disc, we clean the annular tear at the posterior central part of the annulus, we remove the trapped nuclear fragments, we do a little bit of annuloplasty with the RF, and we are sure that we have relieved the back pain. Now, we want also to be sure that the back pain will not recur or will not linger, so we close the annular opening by using a platelet-rich fibrin. Now, this next part of my talk is about closing this annular opening. Now, this is a scan on the left, which is pre-op in a patient. You can see here the patient had a L4-5 related changes with bilateral leg pain with severely reduced walking distance. This was a mid-zone stenosis, and then we operated the patient and closed the annular opening by platelet-rich fibrin plug. And this is a post-operative, 1 year post-operative picture. Almost 1 year, not exactly 1 year, about 11 months, about 10 months. Now, how this has evolved. In 1974, the regenerative potential of the platelets was highlighted by Ross et al. They talked that there are a lot of growth factors in the platelets which help us in healing and help us by regeneration. What we do is, we get the platelets trapped in the fibrin matrix. When they are activated, mitogenic response on bone, periosteum and soft tissue is seen. In 1970, actually, fibrin glue polymerization of thrombin and calcium by using donor plasma was proposed. but the stability and quality was low because of low concentration of fibrinogen, and in those days there was a heightened risk, perceived and actual, of HIV and similar transmission by using these products. Then the platelet concentrates can be broadly classified into two. One is a platelet-rich plasma, which is pure platelets-rich plasma. Leukocytes and platelet-rich plasma can be called as LPRP, that is leukocyte and platelet-rich plasma. The second is platelet-rich fibrin, pure or with leukocytes. We use leukocyte platelet-rich fibrin plug or LPRF. What we do is, the yellow which you see is the plug, red is the RBCs, this is a buffy coat, and this is PPRP, and this is PPRF, more fibrinogen, and this is LPRF with the cells, the platelets. Now, the PRP is components of normal blood clot are 95% RBCs, 5% platelets, less than 1% WBCs, and a few fibrin strands. The limitation of PRP is that we require two-step centrifugation and bovine serum, which is costly, and the risk of disease transmission is there. Now, components of PRP blood clot, this is a normal blood clot, this is a PRP clot, is 4% RBCs, 95% platelets, and 1% WBC. And the preparation requires anticoagulant blood, two-step centrifugation, induced polymerization using calcium chloride or bovine serum. What we do is different. Platelet-rich fibrin or leukocyte and platelet-rich fibrin is a second generation PRP. It accelerates the healing of the soft and the hard tissue. This was initially proposed by Chokran in France in 2001. It does not require any gellifying agent. Not more than centrifugation of natural blood without additives is the basic process. Platelets and leukocyte cytokines are important part in their role and the play which they have in healing of this biomaterial. But fibrin matrix supporting them is very useful. So PRP fibrin is non-physiological, but in PRF it is physiological. I mean, the fibrin which comes in this clot, it gives you a fibrin matrix on which the cells are there, and this is very helpful. Now, there is no biochemical handling of blood. It is simplified, cost-effective process. Use of bovine thrombin and anticoagulants are not required. There is a favorable healing due to slow polymerization. More efficient cell migration and proliferation is seen. PRF has supportive effect on immune system, and it also helps in hemostasis. Now, how do we prepare it? We usually do this in the operative theater itself. Normally, we take around 15 to 20 cc of blood in two sterile tubes, 10 cc each, and we centrifuge it at 3000 RPM for 10 minutes in the doctor's centrifuge, which costs about $100. We allow the tubes to stand for 10 minutes further, and this is what gives us the PRF plug. Then we take out this PRF plug with a forceps and insert it into the discectomy site or the endoscopy site by putting it through the working sheath or the working cannula. So this is our doctor's centrifuge. These are the tubes inside. Patient's blood is being taken by the anesthetist. We put it in two tubes to balance them and centrifuge it for 10 minutes at 3000 RPM. Then these plugs are what is we get. These are removed with a sterile precautions, aseptic precautions. These are the two plugs with little bit of RBCs and buffy coat there. We remove these RBCs and use this plug inside the patient, pushed it through the cannula. This is the acellular plasma. This is the fibrin clot. These are red cells. There's a small buffy coat of WBC. So this is the PRF which we use. Now this is the way it is put in the working channel, in the working cannula. It is pushed by the dilator. It is confirmed that it has gone properly at the opening in the annulus by putting the scope back in this working cannula or the surgical cannula, and we confirm that the plug is sitting where it is supposed to be. Now our results of PRF are shown here. This is a patient who is a 41-year-old male with left-sided sciatic pain, and you can see this is what it is. We operated this patient, and this is a picture which shows you what has happened later on, and this is also a picture which will show you what is the result. So this is the area which has shown healing. So this is a pre-operative scan, this is a post-operative scan, this is a post-operative screening where you will find that at L4-5 it is all well healed area of the annulus. Now PRF stimulates the extracellular matrix metabolism of nucleus pulposus and annulus cultured in alginate beads. This is a study, and a conclusion is platelet-rich plasma was effective in stimulating cell proliferation and extracellular matrix metabolism. The response to platelet-rich plasma was greater in the case of annulus fibrosus cells than the nucleus pulposus cells. The local administration of PRP stimulates the intervertebral disc repair. In addition, given the risk of using animal serum for tissue engineering, autologous blood may be more safe and can be favored as a source of growth factors and serum supplements needed for stimulating cells. Now this was about PRP. Now as you know, we are using PRF. So this is autologous platelet-rich plasma realized on intervertebral disc degeneration in rabbit annular puncture, and conclusion is if we have administered active PRP realized induced a reparative effect, and the results suggest that use of autologous PRP realized is safe and can lead to a clinical application. So we have shown you the use of PRP, PRF. We normally use PRF if you are only going to inject the disc where it is a chemical problem and you hope for healing of the annular tear because it is leaking. Only PRP can be used. But in all surgical cases, we use a PRF. So this is the way we overcome the opening in the annulus left at the end of the surgery and induce the healing of this area. This is a biological solution. We have done the costing of it, and the costing is not more than $1. All the other alternatives like hydrogels and similar cost upwards of $1,000, which is not affordable, which is of course not necessary also. Thank you.